insurance salesman, eats out a lot of clients, no physical activity, big BMI, blood pressure reasonable, type 2 diabetes for 10 years, never in good control. A1C's never been less than 7%. He's got hypertension, dyslipidemia, and he doesn't wear a CPAP. How many of you have patients who don't wear their CPAP? Is this common? You know, I don't have sleep apnea, so I completely sympathize. The problem is it's all about patient education, trying to understand the implications of untreated obstructive sleep apnea. A1C is awful. Fasting glucose is awful. He doesn't check his glucose. This doesn't sound like anybody we take care of. He tries to check once a day, but you know, sometimes, doc, I just can't get around to it. So he's on metformin at maximum dose, glimepiride at a dose that I caution people, I don't think you get a lot more bang for your buck at 4 milligrams. For 8 milligrams, you just increase your hypoglycemia risk. Linagliptin, which is the DPP-4 inhibitor, Tradjenta. He's also on the usual, for the purposes of this, he's on ACE inhibitor, thiazide, statin. He's on all the other appropriate medications. What would you like to know before starting him on basal insulin? Because I'm assuming at 10.4 on triple therapy, how many people would not start him on basal insulin? He would not want to, yes. But you're going to coach him right through that, right? The fasting glucose at 228 and A1C at 10.4. This guy needs efficacy. He needs some serious efficacy in the medicines you put him on. What else would you like to know about Bill? Some of the usual stuff, right? What are you eating? Can we get you to a dietitian? Can we intensify your walking program? Can we find a way around your travel schedule to make this predictable? Are you getting your glargine in consistently every night because you're on the road? Or do you leave it at home for 3 nights in a row? I mean, it's not insulin, I mean, medicines and that kind of thing. So you want to know all the same sort of stuff, okay? So you start it. How do you start basal insulin? I want to know you guys. How do you start basal insulin? Anyone? What do you do in your practice?
Well, if they're very high, I'll give them 10 units. You go up 2 units every 2 days. It'll take you 3 to 5 months to get them anywhere you need to be.
You stole my script.
I'll
I'll repeat what you said too.
Start them on 30 or 40, and I never get hypoglycemia if it's someone with normal kidney function.
Right. So what he said is I won't start him on 10 units and go by 2 units every 2 days and titrate to what? A fasting glucose, right? Because that's how you titrate a basal insulin. And there's 2 on the market. There's Levemir and there's glargine. There are new ones coming on. There's a pegylated Lispro that's coming out of Lilly that's in phase 3 clinical trials that actually is associated with weight loss. Interesting, works through the liver. So, yeah.
Is the formula 0.2 units per kilogram or is it 0.5? Because I'm getting 2 from 2 stuff.
Yeah, let me address that issue. So the question is how do you start and how do you know when you got enough? So with a person who's very insulin resistant, obese, and overweight, please do not sneak up on their fasting glucose. This guy's got an A1C at 10.4, starting at 10 units. Most people, you're aggressive at 30 to 40, most people would start at 20 units. You can have them call you every 3 days, or you can give them a titration algorithm that works. You can do 2 units every 2 days, you can do 3 units every 3 days. It doesn't matter as long as it's a reasonable approach in getting the goal, because there's been enough clinical trials and studies and papers showing different ways to do it. I tend to do the 3 units every 3 days. And so I would start this guy at least 20 units. Titrate until, and so that's what they're doing here. Titrate 20 units. If you've got a small person, if this were a female who weighed 130 pounds, you'd be starting at 10 units. Okay? Yeah.
I just want to get your advice. Is it, let's say, 0.5 units per kilogram per day, divided by, of course, and then divided by 2 or divided by 3? So you get 1/3 of that, you give the basal, and the 2/3, you give the bolus.
Right. So I think what you're asking is in a basal bolus regimen, it's really supposed to be 50-50. So 50% basal, 50% rapid acting analog divided by the 3 meals or the 2 meals or however you're going to do that. But right now we're just doing basal. So what you're supposed to do is start with 0.1 to 0.2 units per kilo and titrate up. In this case, I'm pushing this guy's going to be about 100 kilos, 20 units is about 0.2. And he said he starts at 0.3, 0.4. That's fine. It's a little aggressive. But you've had the conversation with about hypoglycemia. So you look here, and you see that he has gotten down to here. Are you satisfied? Yeah. Okay? So you've talked about it, you got his fasting glucose down, but now he's starting to gain weight. He's eating snacks in the middle of the night because he's starving. And he gets packing snacks during the days. He gets grumpy if his insulin's late, or his lunch is late, sorry. What's happening? He's getting hypoglycemic, isn't he? So here's his glucose log from the past 2 weeks. Have you seen this before in your patients? So you've got a person who's doing what we in the diabetes lexicon call defensive eating. He's defending against those low spells. Now he's finding out that even with defensive eating, he's still getting low. So what he does is he gets to 68 and he's going to do eating insulin the next night. Okay? And sure enough, his glucose has started coming up. So then he gets before to sell 42 units, right? And it starts to come up, but then he has a 70-40, stops it again. And his glucose has come up. And that night that he had an 82, he's 0 again. So you see the pattern. What would you do with him? Education. What would you do with the glargine dose? Lower it. Right. He's getting hypoglycemia.
Well, I just have a problem with, this is a guy whose blood sugar has probably been up for maybe a year. What's the big rush?
There isn't any big rush. That's exactly right.
So why even start as aggressively as he would?
Good point. I mean, there is no hurry as long as you have a game plan towards reaching the goal. I would argue that if you want to take 3 to 6 months to get him under control, that's fine. Do I
Maybe
think?
avoid some of these issues.
Maybe. That's exactly right. And what happened was, you don't know what happened with him. Let's say we got him up to the 36 units, right? Or the 40 units. And then all of a sudden, maybe he did stop some of the eating, and he started maybe walking a little bit more, and all of a sudden that's too much. So it's all about education. I think you're right. There's no rush to get him under control in an immediate nature. Take your time. Safety's the key with this guy. 10 years of poorly controlled diabetes, 3 to 6 months to get him under control. And remember, you've already lowered his A1C 1.5, 2 points just by starting basal insulin probably in this guy who's this high. So you've already made huge progress. Your point is he's probably out of glucose toxicity. He's probably not thirsty. He's not peeing all the time. He's already probably feeling better. So lower the glargine. And we already talked about that. And so what do you need from Bill besides fastings? You need glucose logs. I can't get around, you're just going to have glucose logs. You're going to have feedback. He's got to start checking his glucose so you can figure out what to do. So, they reduced his basal insulin to 36 units. He's not taking glimepiride. That's another major point. You had another hypoglycemic potentially producing agent on top of another basal insulin. So, you stop the glimepiride, you've still got him a linagliptin. He's lost 8 pounds from snacking less, but he's still been thirsty at night.
Why just take him on a 42 basal and just get rid of the liquid?
Well, his point was, can you just get rid of the glimepiride and leave him at the same basal? I think when you've got somebody this hypoglycemic, you got to try to do both, and if you need more basal, again. Remember, glimepiride is probably affecting the postprandial, and it's in combination that it's doing it. So he started checking his glucose at other times of the day, and just look at the pattern real quick and tell me what you see. Because we're about out of time.
He eats more of his travel.
And look at his dinner times. So what would your strategy be with this gentleman? Get regular insulin.
Is that bedtime, is that PPJ?
Bedtime, postprandial glucoses. I think we can see pretty readily his problem is bedtime. His dinner is too big. So most people would recommend looking at this and saying, let's start him on pre-meal insulin. Just one pre-meal insulin injection and see how it does. And most of the recommendations are to start with 4 units. Because 4 units, why 4 units? Why is that picked? Why is that the big recommendation? Nobody knows. It was pulled out of the sky. It was done in a study. That's why we all know all these things. But 4 units is enough to see a difference, but not enough to probably bottom him out. And then proceed by 2 units every couple of days until you get postprandial down where you like it. If you lower his postprandial before he goes to bed, be careful about the basal insulin as well. Okay, so you may need to do a little bit of both. And some people will say decrease that basal insulin by 10%. Okay, I like analog insulins better than regular. If cost is an issue, certainly you may have to go with just cost. But the analogs are much more physiologic, you know, and you've got 3 on the market. You've got glulisine, Lispro, and Aspart, which is Humalog, Novolog, and the very seldom used Apedra, which is a great medicine. And then when you do that, what happened? Look at his basal rate, basal insulin. It's down to 32. But look at the consistency here. Most patients will not be under control with a basal insulin in one meal time, but about 30% of them will. Another 30% with 2 shots of a rapid acting basal, and then some need full basal bolus therapy. I didn't have time today to get into premixed insulins and Sera 30. If you get past 0.5 units per kilogram on basal insulin, it's time to start thinking about postprandial insulin. Okay, that's kind of, so think 0.1 to 0.2 to get them started. And again, it depends on how out of control they are. When you get to about 0.5 units, so if you got a 100 kilo guy and you're getting up to 50 units of basal insulin, yeah, that wouldn't push it a lot further unless you have clear evidence their fasting glucoses are really, really high.